Aloha! We are representing the University of Hawaii at Manoa and are supported by the National Science Foundation. For the 9th International Conference on Global Health Challenges, our topic is Epidemiological Model of the Spread of COVID-19 and Hawaii's Challenging Fight Against the Disease. These are our team members. Since our team is growing with a large number, not everyone is in this picture, but their names are surely mentioned here. Oahu in Hawaii and Nice in France are basically antithetical to each other. Despite the distance, as everyone else around the world, we were taken by surprise with this global pandemic and we're struggling to address this challenge. Before going more in depth into the subject, let us take a little tour. This is the island of Oahu, the most populated among the 8 beautiful islands of Hawaii. In Oahu, here lies our campus, the University of Hawaii at Manoa.
Alright, so in this part we're going to discuss the epidemiological model that we did put together in order to try to analyze the spread of COVID-19 in Hawaii and all the challenges that we've been going through so far and that are ahead of us. So here you have the name of the team. Myself, my colleague from math, Yuri Mileko, 2 graduate students from math, Sasha and Trey, and also my colleague from the UH Maui Supercomputer, Alice Koenig. All right, so here is the presentation content, the outline. So I'll start with the project overview and talk a little bit about the peculiarity of the situation here in Hawaii compared to other places in order to fight disease, pandemic. Then we'll go into the mathematical modeling and define what we have been using. Once we have that, we're going to be revisiting the past, and that exercise is really to try to understand the parameters in the model that are going to be useful and accurate and describe what happened here in Hawaii, so that we can eventually use that in order to simulate scenario moving forward and to try to understand the impact of various mitigation measures and so on. And at the end, a conclusion and future work. So of course, this is like really scraping the top of the iceberg. There is so much going on. There is a lot of issues that are ahead of us, like vaccine. Then there is the interlacing with the flu, etc. So we're going to do that to discuss all of this, but it's certainly not a finished work. It's just really the beginning of what is going to happen. All right, so let's go back to Hawaii. You've learned a little bit about Hawaii already in the prior part of the presentation where we discussed pandemic in Hawaii. And here we're going to really focus on what it means to be an island, what is different from being an island. So of course is the fact that we are isolated. And so it became at the beginning, it seemed that we were doing really well, and then it became the situation completely reversed. So we've been going through a couple of waves. It depends, of course, the definition that you have for a wave, but we've been going up and down, and we're trying to understand what happened and how we can control the spread in the best situation. We have to understand, so here is being isolated. Is it good or is it bad? Okay. It is good because we can completely cut ourselves from outside travel. And some islands, some places have done that, not even letting, like Samoa, for instance, they did not even let their own resident, their own people to come back once COVID-19 struck. So we haven't been as aggressive as that in Hawaii. One of the issues is Hawaii is very big. It's a US state. And one of the issues is the heavy dependence on the tourism and the hospitality sector. So we've been really crushed in economically with some of the measures that were taken. So here is a short reminder of the course of COVID-19 in Hawaii. You've already seen that in the previous part. So as you know, we started, the first case was in early March. And we started with 1 single detected cases, and then it went up in an exponential growth, of course, on an exponential course. The first stay-at-home order took place on March 25, and it was very effective. We absolutely crushed the curve in Hawaii. We went down to numbers between 0 and 1. So we had big applause. We were stated as the state that was the safest in Hawaii. And it stayed a little bit like that until June, where they started to relax all the mitigation measures. And then that's when things went very alarming. It's an exponential growth, as we know, the disease spread. So it went back up very quickly. And after we crushed the curve actually crushed us. And we went to an alarming 200 plus cases per day, daily cases. Then we were a little concerned about the ICU bed and overwhelming the healthcare system, especially on the outer island, because they are not equipped as much as Oahu. So we had to act, and a second stay-at-home order came in, and we started to decline and take control. We've never went back to 0 or single digit. We've been so far from that time on an equilibrium. We've been on a plateau around 100 daily cases, and I'll come back to that. But the take on that slide is we crushed the curve, and right behind that, the curve crushed us. So what are the lessons that we can learn in order to move forward? So here I'm going to start a little bit with the epidemiological models. So we're going to use a compartmentalized SEIR model. As you'll see, I'll explain the detail of the model, but first let's try to understand what a model can do for a disease spread, because making a good model for a pandemic is very difficult, but it's even harder to use it properly, and there are many reasons for that. There are many unknowns. The parameters they can be only estimation. A pandemic like COVID-19, the disease is new, so there is a lot of things that we don't know about the disease. If you get it once, can you get it a second time? If a lot of questions like that. And another issue that we came across, and we are definitely not the only one, it's a worldwide issue, is that there are no reliable data on how it spread. And there are also no data there is no world agreement on how to collect data about daily cases, about ICU beds. So we are all pending on what usually the Department of Health is agreeable to release. And a third thing is that people are really, really complicated. Like, you cannot just expect that a certain age demographic is going to be compliant because they're more at risk. You cannot expect that in majority or a certain type of people are going to behave in a certain way. It is really a very complex, interlaced network between people, behavior, and the disease. That makes it extremely hard to use. So here is what we have done in order to move forward. So the first key in using the model is to try to understand the past. The past gives you some of the keys to the question that I just raised, like for instance about the transmission. Is it the same everywhere? Does it depend? Maybe the temperature is a factor. Maybe there are other things that we don't know. And then, so that's one thing that we can do with the model, understand the past. And that's going to be sort of the first thing that we're going to do here with the data that we have from Hawaii. Then once you have that and sort of a better idea of the parameters that you are working with, you can go with what if scenario. You cannot do predictive scenario, really. You cannot predict what is going to happen in a month or in 3 months because there are so many unknown. However, you can see how some measures are impacting the outcomes. Those are the what if scenario. And then other typical of questions that we can ask and that we are going to be working on is about the vaccine. Who should receive the vaccine first? What is the amount, the percentage of the population that should be vaccinated so that we see some effect on the curve? And again, this is not necessarily real quantitative prediction. They are more qualitative in order to understand what type of measure should be done and when in order to be more efficient. So for the model, we use a commonly developed SEIR model, okay, that has like those typical 4 categories for people. Susceptible, they're not infected. Then there is the category of exposed. Those are infected but are asymptomatic. You have the infected people, they're infected but they display symptoms. And then you have the category that we call remove or recovered, or for us, the removed, they have embedded recovered of the people that are deceased. Then you have some parameters, the transmission rate between the susceptible and the exposed, then the probability to develop symptoms, and then the recovery rate. So this is the typical SEIR model. And we went a little further and we introduced a generalized SEIR model. This is in order to have some different compartments. We wanted to treat, first of all, we wanted to treat the general community in a different way than the healthcare workers. They're exposed in, they're more exposed to the disease and they mingle less with the community. So the transmission between the two, while it's coupled, it plays in a different ways. And in addition, the compartment that you see here, the exposed and the infected, in each population group, you'll see the equation are going to be very similar. We split them into multiple stages, and the reason is that the progression of the disease can change. It takes about 14 days for the one that are asymptomatic for the disease to run its course. So we're going to have 14 exposed variable, and then for the infected, the same thing. You're infected day 1, day 2, and then you have different stages of symptoms, and you can stay a different length at different stages. Then there is another category that you're going to see. It's the quarantine category. But first, so the dynamic of each population group have 2 distinguished parts. The susceptible individual, and then we have to understand how do they become exposed, and then the dynamic once they're exposed between the rest of the compartment. And we call the hazard rate the parameter that is governing the susceptible individual that can potentially become exposed. So here are all the variables. So S is the susceptible, then we have the EI, the exposed individual, and the I is the index that gives the exposure at a given day. Okay, so E3 is an individual at the 3rd day after being exposed. Then we have EQI. So those are the people that are being exposed, that are asymptomatic, and that are in quarantine. So we introduced this quarantine category here in order to be able to evaluate the impact of contact tracing and then quarantine facility, okay? And the testing, of course. The amount of people that are going to quarantine is also governed by the amount of testing that you have. So testing, contact tracing, quarantine facility is going to be, they're going to be probability that are going to affect the behavior of the variable EQ and IQ. Then we have the traditional IJ. So you can see if you develop symptoms day 1, you have day 1, and then you move into day 2, and then you move into day 3. But once you have symptoms in what we call day 3, it's actually a stage. It's stage 3 of the illness, and we assume that you can stay in stage 3 more than 1 day. And then you have R of T. It is the number of removed people from all of those variables. Here you see a diagram that shows how every variable interact with other variables. So you can see it's quite complicated, and you can go from E0 into EQ1, you can get quarantine, or you can become, you'll not get quarantine, you haven't been traced, or you're not in contact with someone else that had COVID, so you're just moving along and you don't know you have it, of course. And then those also, they communicate with the infected. You can be in EI and then start developing symptoms after any day you've been exposed. So then you get into quarantine or you go into the symptomatics. And then once you reach the second or the third day of being exposed, then you can loop, you can keep being in the same stage of the illness. And so that's just a diagram that shows how all the categories go together. Now the equation for that dynamical system, it's a discrete one. We wrote it as a discrete system. It's not the complete set of equation. It's going to come on the next slide that is here. But the idea, you have the susceptible, you have lambda of t, the hazard rate, 1 minus e to the minus lambda. This is the probability that a susceptible individual becomes exposed. Then you have pi. Those are the probability that someone that has been exposed in day I start developing symptoms. Those are the asymptomatic people. QAI minus 1, this is the probability that as an asymptomatic person, A for asymptomatic, decides to get quarantined. So very likely it's because of testing, contact tracing, or having been in touch with someone that had COVID, that then you decide in a spontaneous way, even though you're not having any symptom, to get into quarantine. And then, so this is for the asymptomatics one. We assume that after 14 days, then you're cleared. The symptomatics here, the I0, I1, and I2, they follow this exact same type of equation, and you just have here the R, the probability that you move to the next stage. So I2, like the first day of symptoms, we assume that you move to the second day, and the second day you move to the third day, and that's sort of what we call the stage 3 of the symptoms. And then for the stage like or like 4 and 5 or 3 and 4, it depends, we started at 0, then you have this probability to stay there, okay, to not move to the next stage of the symptoms, because we have very different type of symptoms that people can exhibit. And then you have the symptomatics that become quarantine, or they can become the symptomatic people that might go into the hospital. So here the probability that we have the QS0, those are the one that go into a managed, so either in the hospital or that get quarantined. And then you have R, this is the category of people that have been removed from the susceptible category. All right, so here is the description for the hazard rate for the community and the healthcare worker. They're slightly different because those interact differently among themselves and in between those two categories. So the hazard rate are key to the probability for susceptible to become exposed. So the main parameter, the main one is the beta that we have here. It's the transmission rate, and it's the sort of a dual cousin to the RT. It varies with time, and it depends on the mitigation measure or other measures that are in place. And then, so here, all the variables sort of impact the transmission rate and the probability for a susceptible. They don't impact the transmission rate. The variable that you have here, they impact the probability for susceptible to become exposed. And here you can see that the healthcare worker, they have a new parameter rho that is in front because their interaction with the community is damped. A lot of them were shielding themselves. They were not living with their family. You have some gamma because if you have symptoms and you're in quarantine, so your chances to spread the virus is smaller, etc. The NC here is the total population that we have that is taken into the calculation for the hazard rate for the community, and then we have a hazard rate for the healthcare worker, but the beta, the transmission, is shared by those two populations. All right. In our work, we focused on Oahu, and this is the most populated island in the chain. Then we have actually 8 islands that are populated, and it will be a very different model, a very different way to look at the other islands. So first of all, the data were much smaller, so it was very, very difficult in order to be able to use efficiently the model. Then the mitigation, the way the mitigation measure are different. The mayor might take a different take on what exactly the stay-at-home order are, which park are open, closed, what are the rules for the travelers. We also have the fact that people interact in a different way on Outer Island than on Oahu, where we have tourism, where we have a different type of life. So we decided to focus on Oahu, and all the data that you're going to see are from Oahu. So first we had we had to choose some parameters, right? So the transmission rate, they're going to be optimized to fit the actual data. This is what we call revisiting the past. In order to understand where we are going to estimate the transmission rate that occur during different period of the spread between March and August. But then there are some other parameters that we have to choose, and those parameters have to reflect some of the condition and some of the disease estimates that has been given by the CDC. So here they reflect, for instance, that the healthcare worker have a limited interaction, a reduced interaction, that the asymptomatic transmission is a little less than the symptomatic transmission, that there are precaution in the hospital, so the healthcare workers have different type of precaution, that there is symptomatic hospitalization. So we went with the average numbers, okay? And also what we found eventually in Hawaii. And then here, those parameters, the PI and the Q and the R. So the PI, those are parameters about the onset of symptoms. The QI, this is the asymptomatic quarantine. So this is going to reflect testing, contact tracing, and quarantine. We're going to quarantine facility. We're going to play with those parameters. We did an estimate on what happened starting in June. Before June 10, there was no contact tracing, so we just assumed people were not quarantining themselves unless they had symptoms. So then there are symptomatic quarantine here, some parameters. And if you get into the stages 4 and 5 of symptoms, then the chances that you quarantine are pretty high. And then transition to the next symptomatic day stage. So the PI and the R here, they were chosen in order to reflect those two estimates that were given by the CDC, which are the fact that about 40% of all infection remain asymptomatic. They do not develop symptoms. And also that the average length of a illness is 17 days. So this is how we choose that R value and our PI value. So they reflect those data. So then we had to choose initial condition. Okay, again, it's going to be optimized over some transmission rates and also the timeline of mitigation measure. Those mitigation measure will be fixed, but that means we're going to have several transmission rates depending at different time, different period over the course of March to August, and those value of the beta will be optimized. However, we need an initial value for our dynamical system. So we have the value, the initial value for the Oahu susceptible population, the susceptible healthcare workers, and then we assume a single not quarantined symptomatic individual. That was the first detected case on Oahu, and everything goes from there. So the goal now is to be fitting the curve from March 6 to August 31st, 2020. This is the first fit that we're going to do. We had those data and we're going to use that in order to understand sort of the value of the transmission rate beta at different stages of the mitigation measure. So so we use some of the data from one of the dashboard that is existing from the Hawaii Data Collaborative for the count of the daily cases, as well as the active hospitalization and active ICU beds. Those came later, starting in July. We didn't have them from the beginning. Then the transmission rate is adjusted to reflect the non-pharmaceutical measures. So I'll show you, you saw a timeline in another part of the presentation of the different mitigation measure, and we took the most important one, and then we optimized the fit using an optimization algorithm. This table provides the transmission rate, the optimized transmission rate based on the different period. that we have, and they're going to be used as a sort of a benchmark for then making moving forward scenario, understanding what is typically the transmission rate when we have a stay-at-home order, etc. All right, so here is a graph that shows the daily fit. So the orange dot are the actual daily cases that we were able to fetch from some of the dashboards. Then you have some of the main mitigation measures that happen here. And then the red line is the fit that we have. So again, remember, so that fit is based on just optimized transmission rate. Everything is fixed and then it is also based on a single initial case that happened on March 6. Then we have made some assumption also about contact tracing when we did the fit that is here starting in June. They were the Department of Health. There was a lot of controversy, but they claimed that they were doing some contact tracing. We were never able to get the actual number, but we've made some estimate in order to move forward. I'll be a little more precise about that in a few slides. So another illustration is based on those data. We show you the fit for the actual hospitalization, and here the ICU bed. So they're taken as a proportion based on the numbers that we had in Hawaii from the people that are symptomatics, and then from those that goes into the hospital would go into the ICU beds. So you can see the fit. We are a little underfitting, and this is normal because for the hospitalization and the ICU bed, all we have are the data for the entire state, and our fit is only for wow. So while we have most of the cases and most of the hospitalization and the ICU bed and ventilation, there are still some that occurs in the other island. This is why the dots are a little above our model predictions. All right, so let's revisit the past and see if we can make different scenarios. So looking retrospectively, again, about what happened, there were some contact tracing and quarantine measures that took place on June 10, but it happened that we learned after the fact that were fairly minimal, and therefore we're trying to understand what would have happened if the state was more aggressive in their testing, contact tracing, and quarantine facility starting on June 10, because June 10, we were doing really well, and we were plateauing at single digit for a little while, and then it suddenly completely exploded and went out of control. So here is what would have happened. Okay, so we assume that the contact tracing and quarantine facility and testing that was in place at the time catched about 14.3% of the asymptomatic population. In the following way, 5% after 5 days of exposure, 5% after 6 days, and 5% after 7 days. And this is how we write that scenario. So we're going to see that in the next few slides. So the first number before the 2 points here, 5, 6, and 7 are when the people are catched. And then 0.05 are the percentage of exposed people, asymptomatic people, that are catched at that time. Okay, so there are several factors, of course, that affect the number of asymptomatics that you catch. There is improved testing. The more you test, the more you can detect asymptomatic people. We had then in September some surge, August, September, some surge testing that were dedicated to asymptomatic people, but that happened way after we went in that very alarming state of 200 plus cases. Also increased contact tracing, that's going to help, and then dedicated quarantine facility. That last point might seem forgotten usually, but here we have a lot of family that live in multiracial in community, and they cannot quarantine. They don't have the space at home, they cannot go, or they have to go to work, or so we have to provide them with dedicated quarantine facility if we want to make sure that we remove them from the pool of people that can expose others, that can transmit the virus to others. All right, so we studied two things. So first of all, The main question we had then was, is it better to catch people early, or is it better to catch maybe more people and a day or two later? So what is the most dominant impact of having efficient testing, contact tracing, and quarantine facility? So here, testing, the more testing you do, the earlier, and the better contact tracing, the earlier you're going to be able to put people into quarantine, the asymptomatic people, and they'll have less time in order to transmit the disease. So here you can see, like the first row is exactly what the estimate that we have of what happened. So then you can see here we are estimating that instead of catching the people, still with the same amount, we're not catching more, but we're catching them earlier. Instead of catching them at day 5, 6, and 7, we catch the asymptomatic people at day 3, 4, and 5. So you can see a reduction in the number, especially of the ICU bed. You see a reduction in the daily cases. And it might seem that it's not big, but when you start translating this into economical, financial aspect of what it costs to have someone in the ICU, you can see that you get in the million. I'll go into this a little later. And then, like here, if we assume that we were actually catching more than just 5%, but 10% on day 5, 6, 7, this is what we would have. And then this is how we would have been able to decrease this number if we were to catch them a little earlier. And then there is also the fact that you can impact the volume of the asymptomatic people that goes into quarantine. This is done by a quarantine facility, and again, increased testing and increased contact tracing. The more contact tracing, the more asymptomatic people you're going to find. And here, this diagram here, this table gives you the impact. So if we were, the first row is always the one that we assumed. So now, if you assume that we would catch 30% of people on day 5, 6, and 7, which means like 65% of the asymptomatic. So this is very aggressive contact tracing. However, you can see how the numbers would go down. And it's a good investment because this is saving millions of dollars, really. And this is like by augmenting contact tracing force, you give jobs. And so it is really a win-win situation. So the alternate scenario that we have, they are here. I'll come back to the feed afterwards. But we assume the combination of catching them earlier and catching them more at different days. And this is how you would reduce the daily cases, the hospitalization, and the bed. This is just a little snapshot of the capability, the hospital capability that we have here on Oahu. Maybe it's the entire state. I'm not sure now. I think it's the entire state actually. But like we could really overwhelm them very quickly. So investing in those capability would reduce. Look at what the ICU from 944 we would decrease to 242. And here you have the fit, right? The red one is the fit for the actual data. And those two are increased contact tracing, testing, and quarantine capability. And this is where we could have been, provided we were ready on June 10 with the proper and efficient workforce in order to do the testing, contact tracing, and quarantine facilities. So a little bit of a discussion to close that first revisiting the past. So again, Zoom demonstrated the efficiency on the data. Zoom on the data that we had, it demonstrated the efficiency and good timing of the first stay-at-home order, but also the data demonstrated how the state was not ready to actually come out from that stay-at-home order, unfortunately, and we went from, again, doing really well to a very alarming situation. Contact tracing, testing, quarantine, we showed that if we traced and quarantined successfully 52% of the asymptomatic population, and dominantly after day 3 of being exposed, we would have seen a huge reduction in total daily cases and 74% for the hospitalization and the ICU bed. So that's a huge decrease. And it was understood. The state understood that, and they came up. There was, again, a lot of controversy, but then they started working. They ramped up the contact tracer on the island, on Oahu, and also on the other islands. So now we're going to discuss a little bit about moving forward. So again, this is not predictions. Those are scenarios based on the data, on the parameters that we understand and how we can use them, those transmission parameters, based on different mitigation measures as we move forward. So we want to understand how to address some new challenges, such that the fact that travelers are going to be, they are actually now coming. It's been 2 days. When we did the simulation, they were not allowed yet, so they're not there, but that's something to take into account. Schools, they've been talking about opening the schools. Some of the private schools are actually open. The public schools are not yet open. Then we have the holidays coming up with Thanksgiving. We had a new stay-at-home order. Actually, the situation became so alarming that in August, they closed the beaches and the park. We couldn't hike. They basically closed the outdoor access. And then, since the number were not coming down, they decided for a second stay-at-home order that started on August 27, and that lasted until sometime in October or September. Now I don't know, because there have been so many mitigation measures that it's really hard to keep track. But okay, we have it here. It lasted until October 5. So the first scenario that we're making is that we're assuming very aggressive contact tracing. We're assuming we're catching 78% of the asymptomatic people between day 2 and 4. So that's not realistic, okay? But we're assuming that, and we're combining that with the same transmission rate as the one that happened after June 10. So we want basically we want to try to understand whether testing, contact tracing, and quarantine facility can solely help us to control the curve. Then the scenario 2 and 3, we have two different scenarios where we assume more compliance from the individual. So now we have masks, and people, outside, inside, you have to wear a mask, and people they got scared with the big exponential growth that we have, so they behave in a better way. So we are assuming that the compliance is going to be better than when we came out of the first stay-at-home order, coming out from the second stay-at-home order, and we assume better compliance and smaller contact tracing. That is sort of realistic. Still pretty high, 49% of asymptomatic individuals between day 2 and 4. So smaller, doable, but higher compliance from the people. And scenario 2 is with the most aggressive contact tracing. Scenario 3 is with the same compliance, higher compliance, and a little more relaxed contact tracing. You can see here the plot of the 3 different scenarios. So scenario 1 is the plain line, and you can see that at first the plain line was actually beneficial compared to the other one. So it's the scenario with extremely aggressive contact tracing and low compliance. So it is this one that you have seen here. You can see it started better, but then eventually after the second stay-at-home order is lifted up, then it goes back very quickly in an exponential way. The 2 dashed line corresponds to the scenario 2 and 3, which are with higher compliance from individual and different types of contact tracing. So we can see that the 2 dash line have the same high compliance from individual, but the dot dash has a slightly higher contact tracing, testing, and quarantine facility. And you can see that it is able to actually stabilize the count around like a little above 100, which is not very far from what we have been observing in Hawaii since we lifted the second stay-at-home order. All right, so here, the peak for each scenario. The question is, okay, here the simulation goes until December 31st, but what happened after? So in cases for the scenario 2, it started to decrease in early 2021. And the difference is that for the other two scenario that you have 1 and 3 here, it keeps increasing until some point in the spring of 2021, while this one really has the peak that is here, and it starts decreasing afterwards. So that puts scenario number 2 ahead of the 2 by a big margin. So scenario 1 has a peak of 594 daily cases that would occur in April, and the scenario 3 would be 541 cases. So for scenario 2, the best scenario that we have, so this one that is sort of controlling, stabilizing the curve, the maximum daily cases will not exceed the 193, and it will occur in early December. That will mostly likely be due to the Thanksgiving holidays. Okay, so the discussion that we can have and the take of that, the conclusion is that really we have to control, in order to be able to control the curve, we need both quite aggressive asymptomatic quarantine, okay, an aggressive number of asymptomatic people that go into quarantine, so we break down the spread, and also a high compliance from the population. So here the high compliance, it's unclear how you decrease the transmission rate. One way to decrease that is social distancing, is keeping the mask, and try to stay at home as much as possible. Okay, but again, the takeout is that we need both combined. One cannot be the sole driver of the effort. It's individual behavior by the people to comply, and global behavior by state regulation and contact tracing, so we avoid a huge spread. So the conclusion of all that happened is that when we visited the past, if we took charge of good contact tracing at the beginning in June 10, when the numbers were under single digit, we would now be under 50 daily cases. So now it would have still required some compliance from the people, as we've seen from the moving forward scenario, in order to stay under that 50 daily cases. Then a little word about the economic impact. The best alternate scenario was saving about 10 million cases. That was when we visited the past. But now, if we compare the forecasting scenario going forward, scenario 2 saved more than 12 million compared to scenario 3. And scenario 1 saves almost 4 million compared to scenario 3. So remember that scenario 3 is the worst one. So that one, the plain one, even though it keeps growing exponentially and you don't want that, there is a gain of 3 million, but the one that controlled has a gain of 12 million compared to the other scenario. So really, it's economically very valuable, and also most importantly, in terms of saving people's life and avoiding people to get sick. So the future work. Now, we've been on a bubble, okay? And exactly last week on Thursday, the bubble opened up back to travelers. So they are allowed to come back, provided that they have a negative test, some specific tests, one that has been approved by the state of Hawaii. So the first day that this was installed and implemented, we had 10,000 travelers coming back. It was a mix of tourist and resident, with a majority of tourists, but non-negligible resident coming back. So as we take that into account, we need to be able to differentiate tourist and resident, because they do not mingle with the actual population in the same way. The residents are likely going to be the main driver, because that's going to generate a lot of social interaction with the actual Hawaii population, and therefore a community spread. So we have to watch the number. It's so recent that we don't know how it's going to go. We don't know if the daily cases are going to go up. We don't know if the number of travelers coming back are going to go up. Different islands have different measure for the travelers, so it has been a little bit of a blur, a little bit confusing, and we have to wait 2 to 3 weeks in order to see how everything is going to work out, and whether we need maybe backpedal some of those measures, or if we can continue to move forward. So then our next work that is down the line and that we started tackling is to add vaccination. We're going to add a new category of people that are going to be people that are going to get the vaccine, okay? And they're going to interact in a very different way. They're going to be spread at a very low number, but not completely zero, because you can be vaccinated and still get the virus. As for the flu, likely, we don't know actually, because there was never a vaccine, so it's not very clear how long the vaccine is efficient, how effective is the vaccine, etc. And then we have also to understand, and that was mentioned in the part where we discussed the pandemic in Hawaii, how the flu is going to interact with COVID-19. So that's also a big unknown. So this is for the work that we have done. And here, thank you a lot for listening. And here, this picture that you have shows the number of cases. Somehow, that data has been difficult to gather, but it's number of cases based on zip codes. And here you can see Oahu. That was back a few months ago, so this is not very reflective of what we have now. We have a much higher number count of cases, but having that type of information could help us to do some spatial network and understand how zip codes interact between each other. And it could, for instance, shows us how one zip code might be feeding off each other or from another one, or how maybe if one zip code gets higher cases, what is the next zip code that is increasing, or like to see some sort of spatial dynamic at the local level between that virus. All right, so this closes up the modeling presentation.